when it comes to research around I-CBT for BDD, there's only one study. It's being used in Canada, probably some other countries for BDD, but I-CBT sees BDD the same as OCD, and there, as we know, many studies for I-CBT and evidence-based, and we use the exact same protocol. So when Fred told me, when I learned about I-CBT in February of last year, I had this client I was working with BDD, and he said, "Yeah, it's evidence-based for BDD." And I didn't go any further. I said, "Okay, well, I'll try it." And I just incorporated. She also had OCD and BDD. That's why she came to me, because, like I said, I'm not a specialist in BDD, or I wasn't a specialist in BDD. But this client, well, first, let me tell you what BDD is. It's a preoccupation with one or more perceived defects or flaws in physical appearance. The individual performs repetitive behaviors or mental acts in response to the appearance concerns, and it causes significant distress or impairment in social work or other important areas. And that is the DSM criteria. So this first case, and I have a social media consent release from her. She would actually come in here and speak herself if I invited her. She's offered before. She's so thrilled with the progress that she's made. But she's a young adult female. She immigrated here from Eastern Europe, a very impoverished country. When I met her, when she got here, shortly after she got here, she met a man. She got married quickly after, had a baby. And so when I met her, she was married, stay-at-home mom. Prior to us meeting, just a few months, she had gone to the ER with suicidal ideations. They didn't hospitalize her. They put her on medicine. And she came to me for depression, anxiety, and panic attacks. And I recognized the OCD. She had harm-themed OCD, and what I thought of at the time was relationship OCD, because she was constantly obsessing over her husband, looking at other women, checking his social media, constantly confronting him, and she would get really angry. She would avoid going out because she knew she was going to run into some blonde with big boobs, and it was going to set her off. And it was a pretty bad experience. We treated both OCD and ROCD with ERP, and the OCD abated. I mean, she wasn't worried so much about harm coming to her son. The ROCD, or what I assessed as ROCD at the time, because I was not a BDD specialist, but what I assessed as ROCD at the time would respond to response prevention, but exposures didn't work. We would do imaginal exposures. Her anxiety wouldn't even get up because we were doing exposures around her husband cheating on her or looking at other women. Those things didn't bother her, and it didn't work very well. It wasn't until a year in that she decided to go back to work. And, this was a woman who would show up on my screen, from home, no makeup on, her hair all up in, a bun or whatever, and just a cute young lady. I had no idea about her appearance concerns. I had assessed for some perfectionism because she would change clothes multiple times before she left out. But when she went to work, the first couple of weeks after her first paycheck, she shows up on screen from work on her lunch break with full makeup on. Her lips are plumped so full, and she had gotten Botox with her first paycheck. She went and got fillers and Botox, and what she self-described to me was she liked to put on makeup to look like a transvestite. She had so much makeup. She didn't look like the same person. I was in shock. And then I started to think this might be BDD instead of ROCD. And I went over that with her. This was January of 2022. And she agreed that it was probably BDD. She was running to the bathroom multiple times a day to make sure her lips had not deflated from her injections, and was spending a lot of time putting on makeup. And so we started to explore that. And at the time, I didn't know I-CBT. So Australia has this really good workbook for BDD, and we started working through that. She wouldn't really do her homework. It just wasn't hitting anywhere with her. So I learned I-CBT a few months in, and said, well, let's try this. It couldn't hurt. She was in agreement. She knew we were learning together, and literally we were learning together. So we did the obsessional sequence, and these were the sequence. Just anytime there was no real trigger. She would get the thought, my lips might be getting smaller. And so this is the obsessional sequence that's specific to I-CBT. Looks a little like a functional analysis, but in I-CBT, we focus on the doubt. But we do find out, well, what's the consequence? How would that feel? And then what are the compulsions? And so, her consequences, people won't treat me well. My looks could change and I wouldn't even be aware of it. I would feel insecure and discomfort. So she checked her lips in the mirror multiple times a day, compared photos from the past photos, where she had looked, where her lips had been bigger or smaller, and then she was getting injections. I mean, she went back to get injections. I was almost going to contact the esthetician and or talk to her about contacting the esthetician, but they said, no, your lips are big enough. You can't have any more. And anytime she was around other women, she would walk into a restaurant, scan the restaurant for the pretty women in the room, and immediately be on hypervigilant, high alert. Now, I thought this was ROCD, looking for her husband being attractive, but her doubt, the consequence or the doubt is, my husband is more attracted to other women. And then the consequences, I will be less attractive than other women. And then she'll feel bad knowing people don't like, I think I actually, that's a consequence from somebody else, but she'll feel bad. And then her compulsions was to constantly check his social media. She had all of his passwords. We go on and check that. She was seeking reassurance from him. Oh, and comparing herself to other women, confronting him constantly. They were constantly arguing over this. And he had some indiscretions when they were dating. So there was some relevance here a little bit, and constantly changing outfits before she went out to make sure she looked really, really good. And I wasn't even convinced when we started working on this that this wasn't ROCD totally, that it was all BDD, but it pans out. So other areas of focus that she was concerned about are her boobs are too small, her jaw is too wide. She had been researching reconstruction surgery on her jaw, and in the country she came from, all the women had dark hair and were very, very skinny and small boobed. And coming here, it really triggered women here get breast augmentation, and there's so many blondes here. So she really focused on the fact that her hair was dark and not blonde like the pretty women here that she saw. And she felt like, like many people with BDD, this feeling that if I'm not pretty, I'm not going to have the opportunities that other people have. And so she would feel insecure and she would fail at life. So constantly checking her appearance, seeking reassurance, researching cosmetic surgery, and ruminating over how she looked. So this is module 1, where we're just identifying the sequence in I-CBT. It's the exact same thing as we do with OCD. And at the time, I did not have the manuals for BDD. They were in French and we translated them, and we are updating them now to be more consistent with the I-CBT current manuals. So here are the reasons why she believed that. Now, with BDD, I just take one. Typically, when I'm working with BDD and OCD, when I get to module 2, we're looking for the reasoning process behind the doubt. What are the reasoning? What are the reasons? So we had a couple, but for her, we just did the two doubts related to her BDD. Actually, probably at this time, I was still thinking that it was ROCD, because I put this down here too. So my lips might be getting smaller, and her reasons are, well, lips do change based on water retention, which in our reasoning, we have some reasoning stratagems, which are just prompts really to get people to think about why they believe what they believe. When I'm doing the module 2, I kind of set those aside and let the person just talk. And if they get stuck, I'll pull out those reasonings, or at the end, I'll say, well, are there any rules associated with lips and how people look about lips? So here are the ones she said. Last year, when they started getting smaller, I didn't even realize it. So that's under personal experience and the reasoning stratagems. She said, I did have injections, so my lips will get smaller. I mean, that stuff does dissipate in your lips, get absorbed. So those are abstract facts. Your lips aren't going to be, you're not going to maintain that cosmetic surgery or procedure forever. And then she said, in my country, people think you are hot with big lips, and it's also a status symbol. So that's a general rule. And then another personal experience is, I don't like how my lips looked when they were smaller. And this one was interesting. We had a whole long conversation about this at the bottom. You can see it. She said, ugly people aren't happy. And she believed that. There was no doubt. We went back and forth about happiness, and she absolutely believed that ugly people could not be happy. Even if they said they were happy, there was no way they were unattractive people. I was a little shocked. So, and then the reasoning strategies for my husband might be more attracted to other women. Well, he's told her about other women he thought was attractive. And there was some linguistics there about what does attractive means. And she had in her mind that attractive meant sexually, always sexually attractive. If you were attractive, and there's some indication in the, Webster dictionary that that means that she was participating in my support group, and the whole group was kind of telling her that, guys look at other women, that doesn't mean anything. And it didn't matter to her. So she said, usually if guys look at other girls, they are attractive. General rule, her husband couldn't avert his eyes from her, or she would be on high alert and confronting him. And she said, before I was attractive, no one would look at me. That's personal experience. And if you are looking at someone, then that means you're done with your partner, general rule. And women are treated better if you're pretty. If you're not pretty, you will be treated very poorly. So going back to her history in this country, in Eastern Europe, it was very impoverished. Her family, her mother, her father was absent. Her mother was a bootlegger, had lots of people show up. The kids in the school were very, very mean to her. She didn't have very much money to wear nice clothes, to have her teeth fixed. She got made fun of a lot. And beauty is very much women aspire to be beautiful because then they can get men who make money and can take care of them. And that's, this idea about if you're not attractive, you won't be happy. So, and lots of trauma, small t trauma, people bullying her, people picking on her, no abuse, but her mother being pretty critical of her, things like that. Right. So here's her BDD story. Now, let me go back to the slides. It's really, really important when you're asking for the reasons for the doubt. It's really important just to listen. It's a collaborative process. We're not saying, oh, but people can be happy. That came up actually in another session. We're not, people can't, we're not challenging whether her lips are big or small. We're not challenging. We're just asking her for her reasons. And if you start to challenge the doubt, people are going to get defensive. For one thing with BDD, people really don't like to talk about it. They think that they'll seem vain, that this is silly, or that then they'll be drawing attention to the defect that they hope that you don't see in the first place. So you got to be really sensitive in this module and just listen and validate. Like, yeah, you're right. Lips do change based on water. Yeah, I can understand, how you would see that. Well, that makes sense because we're trying to come about it in a way that gets to their logic. And in each of these ideas actually make sense out of context, but it's not relevant to her, but we'll get to that. So I just had her talk and share now about both of these things. I didn't challenge anything at all. And what my clients will tell me with module 2, which I personally think is the most important module in I-CBT, because I-CBT is a reasoning-based model, and these are the reasons for the doubt. And this is what we're trying to get them to see what their reasons are, which most haven't even thought of before. And I've come to learn also is if you have somebody who's really jealous or really worried about their significant other, assess for a BDD, because that tends to be one of the symptoms or one of the signs of BDD. So the next module we just take these reasonings, and I explain about stories, and you guys are familiar with I-CBT. So in the next module, we're writing stories. But again, what I find often is that the stories don't always correspond exactly with the reasons, and hers did not. Once they get talking, and of course she's had a week to think about why she believes what she believes too. So she's kind of been thinking about this. Why do I believe? And this is these are her words. I didn't prompt her or guide her at all. She said, I just said, let's make a story about why you believe what you believe. And she said, when I see my husband looking at other women, I feel that I'm not good enough to be admired to be the best of the best. I started thinking about all the past situations that were alarming, Like when I looked up some woman on Facebook or when he looked up some woman on Facebook or commented on Twitter. I was pregnant at the time with no documents to leave, and I felt like I could not leave from that situation, like a guy who looks at better women. OCD convinces me that I am worse than any woman that is walking by. When I was younger, I grew up in a very competitive environment. It was hard to get noticed. Teachers were mean. People made fun of my clothing. Growing up, I never had the feeling of being good enough. I never felt respected. Guys did not look at me. Women did not want to be my friend. I never had the balls to say, shut up. There were other people who were mentally stronger than I was. I did not have the confidence. Nobody defended me, and everyone was criticizing me constantly. The people who had phones already were the cool kids. My spot was worse than others. I lived in a really ugly house, and my mom was selling bootleg to put my sister through college. One day, all the cool rich kids were passing by my house, and an alcoholic was coming to my house. I walked around the block for 20 minutes wanting them to be gone, and they were still there when I returned. I felt so embarrassed. Now, here's where she starts to go into her non-BDD story, because she says, if I could go back in time and tell the child, they don't matter. They are all losers. In a few years, you are going to achieve so much. You will be living in America. So she was already starting to shift her thinking at the time. Keep in mind, this is my first case so I'm not even recognizing that at this point. I didn't even really understand I-CBT all that well. I had read most of the book, and I knew I could follow the rules on the module. So then on the same session, like you see the shift in the BDD story. Now this is the non-BDD story. The truth is, we all look at other people. Just because someone is pretty does not mean I am not pretty. Just because the spotlight is on her, it does not mean I am in the dark. He is a man. He looks at other women. It does not mean he's going to cheat. If he doesn't look at her, it does not make her ugly and doesn't make me pretty. If a guy does not look at me, he may have noticed I am pretty. He could be shy, doesn't want to be upset or upset a significant other. He may be trying to be professional. I should be happy with myself and know I'm doing everything I can to like the way I look. Being satisfied with myself will keep me from being upset with the way other people look. For years, I thought I was so ugly, and I can look at those pictures now, and I was a sweet girl with a sweet face. I just did not have the confidence and felt like I was not good enough. I felt weak. I was weak, and that was the only thing wrong. I was cute, smart. I could not tell the bullies to shut up. I'm not weak. Look at me. I moved to another country, learned another language, have a full-time job. I'm a good mama. I am not weak. So notice we didn't focus normally in the BDD modules. We're focusing much more on the specific body part, but with her, it didn't matter. Nowadays, I focus on the actual inferential confusion, but she's resolving this herself just by focusing kind of in more general terms. So the next session, she comes in and she says, I'm better. Things are better. I'm not checking his phone so much. I'm not getting so angry when we're out. And then the following session after that, she comes in and she says, I don't know what you did to me. She has not checked his phone at all. She said, it's working. I went to the mall and out to eat and saw pretty women and did not react at all. It didn't bother me. My husband says I have changed so much. And she's saying, I don't know what you did to me. Keep in mind, these are my first cases. And I'm like, I don't know what I did to you either. This is amazing. It was kind of crazy. And I was just happy it was working. So we get to the vulnerable self theme, and her vulnerable self theme is, I am a person who could be unattractive and be unaware of it, unimportant, irresponsible, and careless, and has low standards. And so the irresponsible and careless comes from, harm coming to her son. So, the rest of modules 5 through 5 through 8 are really intervention. It's giving people the skills that they need. At this point, the inferential confusion is resolved. I didn't have to do response prevention. I didn't have to do exposure. We just worked through the cognitive process of why she believes what she believes. And she's well on her way. We had already resolved the other OCD with ERP, and she's well on her way to being well. But I taught her all those skills. I want to show you the result. Oh, here's something interesting. So when we first started working together at the very beginning, and she's coming on camera with this beautiful son and a beautiful home and a successful husband, and she's got all of these things great in her life. And I send out a list of like 150 values, and I ask them to pick 5 or 10 values that they because we use that with ACT. This was before I even knew I-CBT. These are the values she came back. Out of 150, these are the 4 values. Her values were abundance, beauty, power, and to communicate clearly. And I am looking at this woman who has so many things in her life. And I'm having to control my facial expressions because I can't believe that family, being a mom, and none of those are part of her value system. After module 9, I asked her to repeat her values, and her values had changed so much. She said family, friends, communication, comfort, stability, beauty, knowledge, honesty, and respect, which is so much more whole and reflected the change that she had made in her life. Now we get to the alternative story, the different story. This is module 9. At this point, we're at module 4. Modules 5 through 8 are intervention, teaching her some skills, helping her understand inferential confusion, all of those things. So we get to module 9, and module 9 is where you take, module 3, where we're doing the BDD story and the non-BDD story is somewhat of a intellectual exercise. This is a different story is based on real life, observable events, things that are going on, your personal experience, things you can observe in your real life. And she writes, the truth is that I've always been keeping myself from being who I am. My insecurity was the only thing that made me feel like I am not good enough. My husband loves me, always loved me, and will love me. And the only thing that ever let me feel bad about myself is my intrusive thoughts. I work a very challenging job, which can make one depressed, but despite, I show up there with a good attitude and happy. I have goals to buy a bigger house, to make my son's life better and easier, to get promoted and eventually go to law school to become an attorney. I am funny and I am vibrant. My insecurity was like a treadmill, making me run and run in one spot, thinking beauty will solve my problems. And the truth is, if you do not feel satisfied with yourself, chasing beauty will not help. You will always want more and more. Letting go of my BDD is also letting go of controlling others and manipulating them. Why should one look at only me? Why should one not be allowed to look at other people? And why did I think I can gain special treatment from people by being beautiful? Is this really fair and honest? Letting go of controlling others helps me breathe, having fun, talking to people, admiring them, learning from them, enjoying the smile of your son, a cappuccino after a long day, a smell of wet grass, feeling air hitting your face when you drive with the top down, speeding, going really fast, listening to music and singing it out loud, dancing while doing work in your cubicle, enjoying being yourself and enjoying a good conversation, being there for someone, listening to one struggle. This is what life is about. And if my husband admires someone's appearance, it doesn't make me look bad. It does not take away from my worth. I'm a good friend and a good wife, and every moment of this life is to enjoy. This weekend, my husband and I went out with a pretty girl with blonde hair and big boobs. I could tell Matt liked her, of course. He even asked her how old she was. Just admiring someone's looks does not mean you want to marry them and it's normal. I could admire Matt's friend and it wouldn't mean anything. It is pleasant to spend time with someone who is attractive, but it doesn't mean anything. So these are her scores. At the time I was doing this, again, I wasn't a BDD specialist. I didn't have the BDD Y box. I used the appearance anxiety inventory. And on 12/21/22, her score was a 21, which was 23.9% BDD. Now, this was because of her overvalued ideation. Like she really believed the things she believed. This was probably a very low estimate on her score. On August 2nd, 22nd, her score was 0. She had a blip, and so that was 6%. And then on the normative schedule, on the normative category, in November, she had a little blip. She was at 0.1% on the BDD scale and 11.8% on the normative scale. And just this week, I had her redo the AAI for this presentation, and she had dropped back down to 7.6% on the normative and had stayed at 0.1% on the BDD scale. So that's a pretty significant reduction in her BDD scores. On the inferential confusion questionnaire on February 15th to 22, right before we started I-CBT, she scored a 136. In November 22, she scored a 69. In May, she scored a 35. I think it's somewhere in the 90s. If it's above 90 something, I can't remember the exact number, it indicates clinical significance for ICQ. I mean, yeah, for inferential confusion. So that's those results. Let's see. Another case, Lucy, what time is it?
It is 9:33.
Okay. So these are the really important things to remember. I-CBT sees BDD as having the same faulty reasoning and inferential confusion as OCD. The same treatment process applies. If you're learning I-CBT for OCD, you can apply it to BDD. Modules 1 through 4 are critical. This is where it doesn't always happen this way for OCD, but for BDD, it has happened 90% of the time in my cases that their inferential confusion is resolved by module 3. It's really important for BDD. You want to go slow, you want to be validating, you don't want to challenge their thoughts. It's the process is guiding them to understand how they came to their conclusions, and things start to click. You want to, now I didn't do this in this particular presentation, but on all of my cases, if somebody just says I'm ugly, I'm not trying to resolve the inferential confusion and I'm ugly. I ask them why. Well, and then they'll say, well, what is it about you that's ugly? And then they say, well, my forehead is really large, or my eyes aren't the same shape, or for whatever reason. And then we're resolving the inferential confusion. And I find that, like with OCD, you don't have to address every specific thing. Once they start to unravel the inferential confusion, it generalizes to the other areas. And if it doesn't, you can go back and do modules 2 and 3 again. Always assess for BDD. If you were treating OCD, it's very high correlation with BDD. So always assess. People are not likely to bring it up. They're embarrassed to bring it up. They don't want to bring focus to their appearance. And if you do not ask the questions, they will not tell you. So I am going to stop sharing and just have some discussion. And then if we have time, I will present the other case, which is really kind of amazing. I don't know if is Lisa here? So no, I
Yes,
don't. You
I'm
are,
here.
oh, Lisa, I didn't even see you. You're sitting right there. Okay. Does anybody have any questions or thoughts on that?
Well, I don't know if you saw in the chat, but Robin, when you were doing the OC story, she said that is all about BDD though, because this is trauma. So I'm not,
Mhm.
she's not here to specify what she meant by that, but
Absolutely. No, it is trauma, all that she grew up with.
mhm,
Absolutely. And with
yeah,
OCD, even if it's not BDD, OCD
yeah,
gets wrapped up in trauma.
I agree. Mhm.
Yeah, you got to differentiate that out. So, any thoughts? Any questions? No? Okay. I'm going to present.
Amy said, thank you, Margaret, and please thank your client for sharing what amazing resilience.
Thank you. I will. I will.
And it is
She-
amazing. It is amazing.
she's a really funny lady. She's got a pretty well, I won't say that. She has very colorful language. So bringing her on, I probably wouldn't record it. I'll say that. She cracks me up. All right, so I'm going to share the next one because this is really interesting, and Lisa's probably going to pop in here because Lisa referred this client to me, and I saw her for the first time about 5 or 6 weeks ago. So this is a woman who had, and Lisa, correct me if I'm wrong, because I had a really hard time getting social history. She was so much in the bubble, but she's an older adult female. She's married, mother of 2, and she's presented with BDD. She says OCD, but remember, we don't differentiate that a whole lot. But it was body focused OCD or BDD, which is all the same in my opinion these days. She's depression, anxiety, and bipolar 1 disorder, which hit her in her early 20s when she was in Africa doing Peace Corps work, had to come home. It was pretty traumatic, that event. But when she, Lisa referred her to me. I said, I can see her in the summer. And Lisa said, well, can you recommend a higher level of care? And I'm like, oh, that bad. So I triaged her in to try to keep her from going to the hospital or in intensive outpatient. And the first session, actually, prior to the first session, it was kind of a nightmare. She was all over the place in terms of getting technology set up, filling out forms, all of that stuff. And then the first session, we were just trying to get a social history. And all she kept asking me was, should I shave my eyebrows? That was her focus, that her eyebrows were uneven. Should I shave my eyebrows? I constantly had to redirect her about
Margaret,
shaving.
we did that for over a year.
Yeah, I can imagine. That was it. I mean, I just gave up on social history. I thought it'll come out in the wash. And so I'm like, all right, we're just gonna move on, right? It was gonna shave my eyebrows. If I just shave my eyebrows, then it'll all go away. I won't have to see them. I won't have to look at them. And I'm
And
like,
very low insight, which is tricky for me.
yes,
I have
yes.
trouble with that.
Yeah, I trusted the process, Lisa. I just said, I'm not going to worry about the social history. She looked over, I have this long questionnaire for OCD to see if there were any other things on there. She said, nothing. This is it. It hit her 4 years ago. So it was 4 years. She had been hospitalized 3 times. She said, and I came back and asked her, are all of was this a bipolar hospitalization? No, it was all suicidal ideation about these eyebrows. So the
Did she tell you that she'd had something with her bangs prior to the eyebrows?
She did. She told me that in the twin, but that didn't come out till later because
Okay.
we couldn't pass the eyebrow. I couldn't get anything out of her. It was, so we had a session on a Monday and I said, let's meet again. And it was Tuesday or Wednesday. And I said, we're just going to start treatment. I can't, I couldn't get anywhere. So I got her to we did the obsessional sequence and it was pretty quick. It was only one. So we went through modules 1 and 2 on day 2. So she said, anytime she's looking in the mirror, really just anytime, the doubt is my eyebrows are uneven. And then well, what's the consequence? Well, I wouldn't be able to handle it mentally. Now, keep in mind, this woman has had multiple hospitalizations around her bipolar disorder. So I'm sure she's hypervigilant about, and it sounds like her husband is quick to hospitalize her if she starts to become manic. And so that, I mean, I can imagine that being a big consequence for her. And I said, well, how would that feel? I'll feel awkward and deformed. So she was checking her eyebrows very closely in the mirror, tweezing, threading, shaving, seeking reassurance from church members, seeking reassurance from others, ruminating, should touch them to see if they feel symmetrical. Anything else, Lisa, you want to add to that?
She used to take photos of herself, but we stopped that when we were doing ERP.
Yep. And so, yeah, she didn't mention taking photos. She said her kids were disgusted with her. They were so angry at her. I mean, she basically lost 4 years of her teens' lives over this obsession. And her husband was they were all beyond themselves with this.
And she couldn't get past the regret of initially shaving them.
Yeah, and see,
she just keeps coming back to that. If I had just not done that.
And that is on the appearance anxiety inventory. That is one of the questions is focus, a lot of rumination about why you look the way you look.
Uh-huh.
So that, that is a signature of BDD. So our reasons, honestly, guys, we got through modules 1 and 2 in one session, which never happens, but we only have one thing to think about. She did say that how it started was I noticed a small gap at the top of my eyebrows and decided to trim them with the trimmer and accidentally shaved them off. And then she said it was an accident. I didn't mean to do it. It was an accident. So that was it felt like that was a little bit of insight she got there. Maybe she had been blaming herself. And then whether it was an accident or not, this is what she came up with in this module. And as they were growing back in, I felt like they were not growing in right and kept shaving them off. So she said eyebrows, and this was not, I mean, there wasn't anything like huge in her reasoning. She said eyebrows are supposed to look the way they looked before I started this eyebrow thing. And when I went to Sally's, they would say that one eyebrow looked bushier than the other. She said my perspective in the mirror made them look opposite and whack. And one of my neighbors from India has perfect eyebrows, and I would love for my eyebrows to look like hers. Now, did this come out, Lisa, with you?
The neighbor?
Uh-huh.
No.
So this was a new piece, I thought, because I could see her. She said, my daughter thinks it's because of my neighbor. And she said, I just was admiring this neighbor's eyebrows. And I would love for my eyebrows. So she said, do you think that's why I believe this? And I'm like, well, I don't know. And but she kept pondering that. Like maybe that's one of the reasons why. So we put it down there. I said, it's possible that could be it. And then she said, every time I try to do something to make them look better, I make them look worse. Now, keep in mind that I met with her on Monday. On Sunday, she shaved her eyebrows. She had 0 eyebrows when I saw her the first time. So she comes to our next session. I'm not thinking anything has changed, right? Because I don't see it in this session at all. And she says, I am doing great. I'm not looking at my eyebrows hardly at all. I've walked every day this week. At that next session, she was sitting in the Goodwill parking lot because she really likes to go to Goodwill apparently. And she was sitting and we had the session in her car in the Goodwill parking lot. And she said, I said, well, does your family notice a difference? She said, yeah, but they don't trust it. They're not trusting that anything's changed. And Lisa told me this morning, we were talking that this has happened before. I want you guys to realize that the jury's out. I don't know if it's going to stick. It's been about 5 weeks now and she's still doing well, not focusing, but Lisa has some questions if anybody has experience with bipolar. But so, and well, let's see, I didn't even have bother with assessing severity because I couldn't get her to that point on day 1. But I went back 2 weeks ago, last week, and I asked her to do the I-CBT and we got those numbers retrospectively. So she says in her BDD story, when I look in the mirror, my eyebrows look uneven. Now keep in mind, it seems like the inferential confusion is already resolved at this point. She is not worried about her eyebrows. She said, I just don't worry about them. I go all day long and I'm not even thinking about them. So we're doing this as part of the module 3. When I look in the mirror, my eyebrows look uneven. I have strived to have them look perfect. It feels like since I have shaved them so many times that they will not grow in right. My eyebrows feel, and we'll hear that a lot with BD, it feels like they look uneven. One is longer. They seem to be different shapes. I worry that once they grow in, they will not look similar. Other people told me that one eyebrow had longer hair than the other. When I look in the mirror, I just don't know how they look. And we hear that also often too. Like, I really don't know how I look. I can't be sure, which is kind of sad. So her non-BDD story, again, this is her talking. I do very little guiding here. My eyebrows got shaved off at the same time and will grow back at the same time. Checking and rechecking isn't helping the situation. Growing in is a process. It is possible that my eyebrows might grow in at different rates, but it will all eventually grow in. I can be patient and allow my eyebrows to grow back without doing anything to them. Absolutely nothing to them. My eyebrows are not uneven. When I look in the mirror, I can see my eyebrows and they look fine. Feeling my eyebrows are uneven is not a fact. Feelings are not facts. The habit of checking my eyebrows is over. The habit of checking my eyebrows over and over skews my perception of how my eyebrows really look. This is some pretty good clarity. She did bring up, God made us all perfect, and that Lisa asked me if there was some religiosity in there, but it didn't make it into her story. I thought it had. So here are her scores. Her Y-Box 2 score was.
Sorry, Margaret, can I interrupt for a second?
Sure.
There's Amy asked a question that's pertinent to what you were just talking about.
Yeah, go ahead.
What questions do you ask to prompt the non-BDD story?
So what I do, Amy, is I just say, we're going to take an alternative view. We're just going to look at it. And now, sometimes if people are stuck, I will ask them, what would you say to a friend who's just like you? And I get them to take one step away from themselves. And what would you tell a friend who was worried about their eyebrows, or a friend who was worried about their nose or whatever, or if it's OCD? And then taking one step away. And as they're saying in third person what they would say to that friend, I'm writing it in first person, I instead of you. And so, but I'm just really kind of guiding them. I'm saying, let's look at a different view, a non-OCD or a non-BDD viewpoint. So,
Can I ask a question about
yeah.
the non-BDD story?
Mhm.
My eyebrows are not uneven. I struggle with that. I'm an ERP therapist first. It just sounds like reassurance. And earlier you said, we want to validate their experience, and her experience is that they're not even. And
Yeah,
then,
that's
what was
what
the
I
act,
heard.
the act perspective of accepting, how do I live my best life with uneven eyebrows? I can't get all that out of my head.
So I can go back to my notes, Lisa. She said in there, and part of it, when we were discussing this, she did say that she recognizes that things are not supposed to be symmetrical. She did not
Okay.
put it in her, and she did recognize that. She didn't,
Okay.
it wasn't delusional, like my eyebrows are not uneven, but she realized that, symmetry doesn't happen in nature. Things are
Right.
different, right? So she did, but those are her words. So it does
Okay.
sound a little, I agree, it sounds a little bit like reassurance, but she had the cognition that they weren't perfectly even.
Right. Right.
Yeah.
Okay.
Yeah.
Thanks.
Yeah. Thanks for asking that. That's a good point.
I
So,
think, can I just add something to that too?
yeah.
I think what people tend to feel, instead of it being reassurance, is it's grounding, when you get the story right, the alternative story. So, and if it feels like reassurance, then you'll know pretty quickly because they'll go into rumination. So we're kind of looking for more of like a grounded feeling with the
Yeah, it's assurance, right? That's what we use the word assurance. If it's reassurance, you're having to do it over and over and over again.
Yeah, compulsive reassurance, right? Yeah.
So
I'm
I have
gonna-
a question. Can I ask a question too?
Yes.
Like related to that, because we are trying to resolve the doubt that the eyebrows are uneven. Is that correct? Like that is the
Mhm.
primary inference of doubt in this case.
Yes.
So then I wonder, is there any space for my eyebrows are even enough? Does that resolve the doubt, but still allow to know that no eyebrows are perfectly symmetrical?
Yeah, no, I agree. And that came out I think that's a really good point. That came out in the discussion, like when we were discussing it. Like, I know that they're not going to be perfectly even, right? But just in general, when she said my eyebrows are even, she just meant in a general sense. Kind of like, when we talk about tolerating uncertainty, well, we know that anything can happen, anything's possible. It's just a generalized kind of
So
everything's okay.
in this case, she doesn't need to accept, like, oh, I have to accept my eyebrows are uneven and live a valued life anyway. We want her to know her eyebrows are even
Yeah.
enough. Okay.
Enough. Yeah. Good point. Really good point. So, so that was it. Now the jury's out. Lisa's skeptical. I'm skeptical because she had a therapist before Lisa. And how many did just one therapist before?
Nobody ever diagnosed her with OCD or BDD until she came to me. So and I just always called it BDD to her, but she's calling it OCD. And I had even brought it up in the Facebook, the other Facebook group before this one. And somebody said, what does it matter? Because I said, is it OCD? Is it BDD? And somebody said, what does it matter? Right? Because we're going to treat it the same way. But the reason I'm skeptical, in case other people are wondering, is because I have seen a correlation between her mania and a cessation in her OCD BDD symptoms cyclically. So I can't help but wonder if that's what's happening here. Also, medication has been very tricky for her because any of the medications that you would use for OCD type, obsessional thinking tend to make her manic. And so every time she goes on an SSRI that helps her with that, she starts to get manic and her doctors take her off. And so I've been working with her to talk to her doctors about keeping her on a lower dose to just try to see if maybe we could manage both. And then sometimes she just goes off of it completely on her own too, right? Which is very common for people with bipolar disorder, but she stays on her bipolar meds. She just goes on and off of, I think, Zoloft. And so there's a correlation there too. I would want to know what's the status with that, because the medication could be a reason. I guess she's on Zoloft now. Did she go? Because right before I sent her to you, for about a couple of weeks, maybe 3-4 weeks, she'd gone off her Zoloft of her own accord. I asked her why you were doing better.
Mhm.
And she went right back on Margaret before she saw you.
That might be a factor. Let me see what my notes say.
I'm always
Totally.
looking for extraneous variables.
Yes, it might be. It could be a factor. No, she said, well, lithium clonopin, and I've got Zoloft off to the side, so I don't know if Zoloft is, I would have to ask her that. That's a good question.
She had gone back
Um,
on it
I'm gonna
a few days prior to me referring